This
Hello.
conference will now be recorded.
Hi, welcome to session 5 of our incident classification. This is the first round of classifications that we're going to do. My name is Catherine Moran. I'm a radiation therapist in Halifax, and I'm very pleased to be walking you through this session. So some things we're going to cover in this session. We're going to discover and discuss the most commonly reported problem types within the NSER-RT database. We're going to look a little bit about root cause, problem type, and contributing factors. We're going to work through classifying some cases. We're going to look at some incident descriptions and discuss that. Now here's a quick hint. We're going to be asking you to classify an incident. So now would be a really good time to print off a copy of the NSER-RT incident data collection form. So if you need to, go ahead and pause this session and print that form. All right, so when we look at the top reported problem types currently in NSER-RT, and this was reported as of March 19th, 2018, we see that the top 8 problem types are failure to perform on-treatment imaging as per instructions, wrong prescription dose or calculation error, systemic hardware software error, excess imaging dose, wrong missing mislabeled accessories, therapy scheduling errors, wrong patient position, setup point or shift, and then we have this very large bar at the end of other. So within the events reported as of March 2018, other represented 33% of all of our problem types in NSER-RT at that time. So we may have a problem with our problem types. And my goal today is to walk you through those problem types a little bit more and see if we can get a better handle on that. So some common incidents and things to think about. So what do you think about this problem type other, and why are there so many? Think about it for a minute. Why do you think there's so many that are reported as other? I think it's a twofold problem. Number one, I think it could be a lack of an in-depth investigation. So really that propensity to latch on to that first issue, that first problem that you see, and maybe that problem's not on the list of problem types. And if you don't dive a little bit deeper, you may want to choose the problem type other. The second issue that I see with the problem types, choosing other, and why there might be so many, is a conflicting philosophy on classifying versus on root cause analysis versus NSER-RT's problem types. It's a little bit different way of thinking about things, and I'm going to go through that on the next slides. But first, what's the danger in choosing other? Why do you think there's harm in having 33% of our incidents classified as other? For me, it's really a matter of GIGO. Garbage in equals garbage out. If I'm using the NSER-RT database to look through my own problems and find some incidents that happened previously, go back in time, look at incidents, and if 33% of the time my incidents are being classified as other, it's just a big heaping mess that I have to sort through. And if I take that a step further and I want to look at the NSER-RT database as a whole, because I want to look for similar incidents and maybe figure out a similar problem that's happening across the country, and if 33% of our problem types are classified as other, that's a huge population of our incidents that I might not go through because I might not have time to go through them all. I may just focus on the ones that are classified appropriately. In fact, when we were coming up with our very first NSER-RT newsletter, and we were looking through the problem types, we had to be very conscious to also look through this big pile of other incidents, because there might be something very valuable in there, but it is very labor intensive to do that. So that's why we really want to concentrate on making sure that we're classifying using appropriate problem types. Does anything else surprise you on this list? Is it reflective of what you see in daily practice? So for me, it really is reflective of the incidents and how they're classified in my home center. There's an older study that will say that the bulk of radiation therapy related incidents are inputted by frontline radiation therapists, and that's not surprising at all. We work in this care path, this trajectory of tasks, all working together with various levels of quality assurance in between. And it's usually at the point of patient impact that we really notice these things. So it doesn't surprise me at all that the next largest volume of our incidents that are reported is wrong patient setup, position, shift, maybe radiation therapy scheduling errors, or errors related to missing, mislabeled, or damaged accessories. That doesn't surprise me, and it's very reflective of my own practice. So a little bit more about this idea of root cause versus problem type versus contributing factors. So oftentimes these three titles, root cause, problem type, and contributing factors, can get mixed up. And it can cause confusion in your classification, and I think it's one of the main reasons why other is being chosen so often. NSER-RT really moved away from classifying based on root cause and towards problem type. We're not saying in any way that root cause isn't important. As we've learned in the previous lectures, you need to know the root cause in order to fix a problem that's happening in your center. However, NSER-RT isn't classifying based on the many root causes that are out there, but more on the pared down problem types. What's the problem and why do you want to report this? Why is it important to the country? It's not important to the country about that root cause, maybe a documentation error, but more about the problem, what actually happened. So it can be a change in how we think about and classify our incidents. So I have a little example for you. Now, depending on when you're listening to this lecture, this may seem a little bit out of season, but when I was originally putting this lecture together, I was watching the movie Home Alone with my son. It's one of his favorite holiday movies, so we watched it many times. Now, when I was watching it for the first time this year, I thought, wow, this really starts to become more about an incident. And it's a great example of teasing out the difference between the root cause and the problem type and the contributing factors. So let's walk through this incident. So anyone not familiar with the movie, here's the premise. We have a family that's leaving for vacation over the holidays. The house is chaotic with many family members and kids. The father accidentally unplugs the alarm clock. The child, Kevin, acts up and is sent to sleep in the attic by himself. The following morning, everyone wakes up late. Taxis are beeping their horns. There's a mad rush to get everyone up and loaded into the taxis. We have a teenager who does a head count, but accidentally counts the neighbor child who's over visiting. The family leaves for the airport. The family's running through security into their gate. The family boards the plane, but they're all spread out in different sections of the plane. The mother realizes during the flight that they're missing Kevin, and Kevin wakes up home alone. So that's the premise, or the incident description in this case. So let's look at it a little bit differently. If we were to use a method like the 5 whys, and we really drill down through this incident, we're going to find out eureka. The root cause is that dad unplugged the alarm clock, resulting in oversleeping and mass chaos in the morning. Now, this is very important to understand. You need to know this root cause because in this family's case, they may want to start investing in battery backup alarm clocks because, as many of us know, this happens all over again the very next year. Home Alone, Lost in New York. So it's very important that they understand the root cause of this incident. However, if you want to create a national system for incident reporting based on childhood antics in holiday movies, are you going to classify based on the root cause, the number of times dads forget to unplug the alarm clock? Or do you really want to classify based on the problem? Why is this a problem to begin with? It's a problem because the child got left home alone. So that's where NSERRT has really distinguished this. Yes, you can classify based on root cause, but we've decided to classify based on problem type. So we've really looked at what are the various problems in radiation therapy, and we've singled those out. And that's what allows us to have some consistency across the country, because the problems in radiotherapy are similar. But depending on where you are, your processes, your equipment, your personnel, the root cause to those problems may be very different. If we were to set up a classification system based on root cause, you'd have hundreds and hundreds of different data elements to classify. Whereas if we really want to narrow it down, we can classify based on a handful of problems. So from there, you tease out the contributing factors for the problem. And in this case that we're using, the house is overcrowded, it's chaotic, everyone overslept. Taxis are waiting, they're blasting their horns. We have a child who got sent to bed early and they're sleeping in an attic where they normally don't. They counted the wrong number of children, they're rushing, and their seats are split up all over the plane. So we have a root cause where the alarm clock got unplugged. We've got some contributing factors that helped create this chaos. And the real problem is that a child got left home alone. So that's the difference. And I hope this example really helps you to really get that in your mind, the difference between root cause and problem type. So in radiation therapy, often we look at an incident and there was a documentation error. Well, that might be the root cause. There was a documentation error. But we want you to take it one step further and tell us what the problem was. Tell us what that documentation error was about. What did it lead to, or what could it have potentially led to? What's the problem that that documentation error caused? So rather than just choosing other, because you don't see documentation error on the list, tell us what the problem was and choose the appropriate problem type. So what we're going to do now is we're going to go through a number of reclassifications. So these incidents are based on some similar incidents found in NSERRT that were classified as other originally. And I want you to take a moment and we're going to go through them. And I'm going to give you some multiple choice options. You might want to pause after each question and see if you can choose the best classification based on your minimum data set. And then I'll give you what I think is the correct answer. Now, I do caution you that sometimes there could be multiple correct answers. We do understand that nothing is ever perfect and that there are some similarities in the problem types, and it might depend on your center and how you think of incidents or based on the processes in your center.
This conference will now be recorded.
So here's your incident. Head and neck shell was fabricated with one peg not fastened. CT was performed with pegs not secured. So our options for problem types are failure to perform on-treatment imaging per instructions, wrong, misleading, mislabeled, or damaged treatment accessories, wrong anatomical site, excluding laterality, or wrong patient position, setup point, or shift. So go ahead and think about this for a minute. You can look at your MDS and look at the definitions if you'd like. You can pause this if you'd like, and then we'll go on. So I chose B, wrong, missing, mislabeled, or damaged treatment accessory. The use of incorrect treatment accessories or missing, mislabeled, or damaged treatment accessories. This includes accessories for external beam radiotherapy and brachytherapy, such as brachytherapy applicators. So I really felt that since the cast wasn't fabricated with all of its pegs, it really was a treatment accessory issue. So number 2, the incident that was reported was that the patient was treated with dentures in their mouth. So our options are wrong, missing, mislabeled, or damaged treatment accessory, wrong anatomical site, excluding laterality, failure to perform on-treatment imaging per instructions, wrong patient position, setup point, or shift. So I said it was the wrong patient position, setup point, or shift. The incorrect delineation, reference, or use of verification points, or other incorrect patient positioning. So I really felt that if the patient was positioned this time with their mouth more open than it was in simulation because the dentures were in place, then it was really a patient positioning issue. Number 3, incident reported. The patient's start date was delayed due to contouring not being completed. The patient started outside of the ready to treat guideline. Our options can be radiation therapy scheduling error, untimely access to medical care or radiotherapy, inadequate coordination of combined modality care, or wrong target or OAR contour. This is a tricky one. There's multiple options there. What would you choose? So I really said that this was a radiation therapy scheduling error. This is where you really need the definitions to look a little bit deeper. So the definition for the radiation therapy scheduling error is the incorrect coordination of one or more radiation treatment tasks, resulting in a treatment delay or fractionation schedule not being followed, excluding scheduling errors relating to combined modality care or resulting in excessive, insufficient, or inadequate imaging. I really think that if you choose the untimely access to care option, that's really looking at getting onto radiation treatment, all the things that happen, getting the referrals in, access to machines, machine time if something goes down in a machine and causes big wait times for your patients, things like that. The combined modality care option really is dealing with multiple different modalities, so the scheduling between maybe chemo, radiation, surgery, etc. Whereas radiation therapy scheduling error really keeps it in that radiation therapy trajectory of tasks and duties. So number 4, delay in patient starting treatment due to the cancellation by the diagnostic imaging department of the PET scan required for fusion with the planning CT scan. So again, would you choose untimely access to medical care or radiotherapy, inadequate coordination of combined modality care, radiation therapy scheduling error, or failure to perform on-treatment imaging per instructions? In this case, I chose inadequate coordination of combined modality care. The definition here is very clear that it's the inadequate coordination of radiotherapy with surgery or chemotherapy, including but not limited to improper patient handoff or improper insufficient information exchange between medical and/or allied health disciplines and scheduling errors. So I really focused on that insufficient exchange, improper handoff between the allied health disciplines. so the diagnostic imaging department. Number 5, patient missed his target start date because the planner did not assign their name to the planning task. Again, is this an untimely access to medical care or radiotherapy? Is it inadequate coordination of combined modality care? Is it a radiation therapy scheduling error? Or is it failure to perform on-treatment imaging per instruction? So I chose radiation therapy scheduling error again, because again, this is the coordination of one or more specific radiation treatment tasks, resulting in the delay or fractionation schedule not being followed, excluding scheduling errors related to combined modality care, or resulting in excessive or insufficient or inadequate imaging. So really focusing on the fact that this happened within the radiation therapy spectrum of duties and tasks, and it was a scheduling error that caused that. So scheduling of that task or adding of the planner's name, and it resulted in a delay. So number 6, we have a patient being treated with breath hold technique. An extra image was taken as the patient held her breath for the first non-breath hold image. Patient doesn't speak English, heard the machine turn on, and held her breath. So it gets tricky here. We have some various options with imaging. Wrong, missing, mislabeled, or damaged accessories, failure to perform on-treatment imaging per instructions, wrong patient position, setup point, or shift, or excess imaging. Let's look at your definitions and see what you would classify this as. I personally chose excess imaging dose. And the definition there is that it's a failure to perform imaging per policy, procedure, or protocol that results in excess imaging or excess imaging dose. It excludes insufficient, inadequate, or poor quality imaging. Now, there is the other option, is the failure to perform imaging per instruction. And that's a failure to perform per policy, procedure, or protocol that results in insufficient, inadequate, or poor quality imaging. You could go either way with this. I chose it as an excess imaging dose rather than a failure of the therapist not following the proper imaging instructions that led to maybe a poor quality image. So that's why I chose excess imaging dose. So number 7, found on weekly QA after 5 fractions that the KV imaging was being used as per policy, but the RO had written a note that they wanted cone beam CT to be used. So our options again, is it a failure to perform on-treatment imaging per instruction? Is it a radiation therapy scheduling error? Is it excess imaging dose? Or wrong patient position, setup point, or shift? So in this case, I did choose failure to perform on-treatment imaging per instruction. And the definition again is it's the failure to perform imaging per policy, procedure, or protocol that results in insufficient, inadequate, or poor quality imaging. So in this case, it was a failure to follow the instructions of the RO who wanted them to do a cone beam CT. So instead, they were doing KV imaging, which resulted in maybe insufficient imaging information. The RO wanted a cone beam CT. Number 8, imaged times 2 due to human error. Our options here, wrong patient position, setup point, or shift, excess imaging dose, wrong, misleading, or missing, mislabeled, or damaged treatment accessories, failure to perform on-treatment imaging per instruction. So in this case, I chose excess imaging dose, a failure to perform imaging per policy, procedure, or protocol that results in excess imaging or excess imaging dose. Now here's the trick. On incident description that simply says image times 2 due to human error doesn't give us a whole lot of information. So that's the best choice I can make based on the description. So that brings me to our next piece, and that's the quality of narrative. So the quality of that incident description. So data elements are only good for stats purposes and for filtering. To find meaningfulness in the NSERC data, good, solid narratives are equally important. If NSERC is used for your own reporting system, you will never remember the circumstances of imaged times 2 due to human error. If you're using it as a learning or risk mitigation tool for other institutions, there's no meaning in imaged times 2 due to human error. If I'm looking at the NSERC database and all I see is image times 2 due to human error, it doesn't give me very much information. I might look past that incident and move on. I might not put any red flags to it. It might not mean anything. But in actual fact, it could be a big incident. It could be something that I could learn a lot from, but I'm going to skip over it because I'm not learning anything from that description. Combine that poor description with a problem type of other, and it's going to just land in a big heaping pile of incidents that nobody's ever going to learn from. There's no meaningfulness in that. And in order for NSERC to be used by the masses, it really needs to be meaningful. So I suggest you describe the problem, you describe the circumstances. If you changed a policy and you can give us information in your description about what you did, what big eureka moment you had, put it in there. And then it turns into a meaningful classification. So if we use properly classified data elements, avoiding the overuse of other unless absolutely needed, and we have good quality narratives, then we can take the data in the NSERC database from a position where we're all lost in the questions to a position where we can harness those questions to answer common problems. So let's look at that narrative. Image times 2 due to human error. An alternative narrative, without adding too much detail and being too taxing to write, could simply be image times 2 as anatomy settings were incorrect, resulting in poor quality imaging for matching. Well, then the problem type becomes, again, excess imaging dose. Failure to perform imaging for policy or procedure or protocol that results in excess imaging or excess imaging dose. Or we could say image times 2. When the KV imaging was completed, we initiated the first treatment arc. Realized that fields were misordered, and had initiated the backup cone beam CT. We stopped cone beam CT mid-scan, reordered the field, and proceeded with treatment. Again, excess imaging dose. They gave more imaging than needed because they didn't follow protocol. They had actually, by accident, initiated the cone beam CT when they were finished their KV imaging. Another example could be the patient was aligned to an incorrect set of tattoos, as the tattoo document was mislabeled. It was caught on initial imaging. Patient was realigned, image match was successful, and the patient was treated. Well, in this case, the imaging became the safety barrier that caused the incident. It's a safety barrier rather than the problem. And the problem actually becomes the patient's position. And it was the wrong patient position, setup point, or shift. Incorrect delineation, reference, or use of verification points, or other incorrect patient positions. Another example, we take it a step further. Image times 2, as it was discovered on the first image that the incorrect patient was loaded at the console. Discovered that staff were doing callback checks after imaging and prior to the beam initiation. Policy was changed such that the callback check was done prior to imaging. So again, in this case, the imaging became the safety barrier, but the problem was actually that they had the wrong patient on the moded up on the console. And we've also been given a little bit of information about the circumstances that therapists were doing callback checks after imaging before the treatment started, and how they changed that process to mitigate the risk and taught their therapists to do the callback check before the imaging even started. So I hope that goes through the incident descriptions with you a little bit. We're going to look at a case study example now, and then I'm going to ask you to get out your MDS and classify a number of items. All right? So now this case study has a huge narrative, and it doesn't always have to be that large or involved when you're inputting into ENDS or RT. We just really want you to be a little bit more descriptive than image times 2 to human error. So here's an example. Target and organs at risk contouring was completed on planning CT simulation. Prior to radiation oncologists leaving for vacation, the case was sent for peer review due to the area being treated was overlapping with a previously irradiated field. The physician assigned to peer review task had an emergency and was off for 2 weeks without prior notice. Peer review was not completed for more than 2.5 weeks and wasn't picked up on, as there was no formalized process for monitoring overdue radiation oncologist tests. The delay was caught when the medical oncologist asked about the status of the radiotherapy. The radiotherapy plan was quickly approved and treatment was started within 2 working days. The patient was seen by the primary radiation oncologist on the treatment unit day 1 to discuss the delay and assess the patient. The tumor had doubled in size, was now breaking through the skin, and the patient's reported pain had increased by 2 to 3 out of 10 from the time of original CT simulation. Patient and family indicated they were alarmed by the delay in starting treatment, but that they didn't recall being given any information to contact the department and didn't want to appear to be bothering by asking about treatment start date. So this is the example. Now go ahead and pause the feed and look through the example quite a bit and try to classify some important key elements. The acute medical harm, dosimetric harm, the process steps where the incident was discovered and where it occurred, the problem type, the contributing factors, and the ameliorating actions. Go ahead and work through that with your MDS now, and then rejoin me on this session. Oh, one last thing, sorry. Treatment was canceled for that day. Patient was re-CT simulated the next day. New volumes were contoured and the plan was generated and treatment started the following day. Now go ahead and pause this. Okay, let's resume. So the type of incident. I said that this was an actual incident, a patient safety event that is detected after reaching the patient. Now, some people might say that it was a near miss because the treatment delay was caught by the medical oncologist who called asking about the start date. And that's when everything was put into motion. However, because the delay actually led to a patient having increased pain and the tumor doubling in size, then I really can't choose a near miss. So it has to be an actual incident. The acute medical harm. Well, this is really a judgment call based on the information you have about the patient and maybe the input of the radiation oncologist. So I called it a moderate harm. This patient is symptomatic, requiring intervention, additional treatment or operative procedure, prolonged hospital stay, long-term or permanent harm or loss of function. Their pain has increased and the tumor is doubling in size. They required a new CT scan and a new plan, so I said moderate harm. The dosimetric impact. I said that the dosimetric impact was none. And really, this is when an incident reaches the patient but does not involve a dosimetric delivery error. This is why we have a threefold for determining harm: medical harm, dosimetric impact, and latent harm. So in this case, they had acute medical harm, but there was no dosimetric impact. We didn't treat with an incorrect plan. We didn't treat with a radiation plan that didn't fit that new tumor volume. Everything was stopped before treatment and replanned. So dosimetric impact was none. Now the process step. Now I said that the process step occurred at contouring and planning, which includes contouring of target structures, OARs, generation of the treatment plan, including the isodose distribution, treatment plan approval, transfer of plan data, and setup instructions to the radiation oncology system. And the process step detected, I said, was other, because I don't think there's really a process step for the medical oncologist just simply calling and asking about the status of a chart. Now, there could be some disparity in how we classify process steps, and that's okay, because we all come from different institutions that have different resources. Maybe some centers have advanced practice roles that take on different roles than other centers have. So the process steps might be different depending on where you are and what your policies and procedures are, and who divvies up which type of work. And that's okay. Now the problem type. I said it's a radiation therapy scheduling error. It's the incorrect coordination of one or more radiation treatment tasks that resulted in a treatment delay or fractionation schedule not being followed, excluding scheduling errors related to combined modality or resulting in excessive, insufficient, or inadequate imaging. So really, this had to do with the RADONC scheduling the peer review task, and it got scheduled to a RADONC who wasn't in the building. They were off on an emergency. Contributing factors, however, become communication or documentation inadequate, policies and procedures non-existent or inadequate, patient education inadequate, patient or family member medical condition, preference, or behavior, handoffs inadequate. So the handoff of that information from one RADONC to the other wasn't there. There were no policies and procedures for monitoring outdated radiation oncologist tasks. The patients themselves didn't recall being given any information on when their treatment would start, or what would be too long, or who they should call if they have an issue. And they themselves said, really didn't want to be a bother, so we didn't call. So those are some of the contributing factors that I chose. Ameliorating actions. Now, these are the actions that really, what you did in that circumstance for that patient to compensate for harm in that particular case. That is different than the mitigation factors, where you look at what you plan to do in the future to make sure it never happens to another patient again. So the ameliorating actions are, what did you do in this case with this patient? So there was some patient disclosure. We learned from the incident description that the RADONC came and spoke with the patient and told them about the delay. The radiation treatment plan was revised and the treatment volume was revised. A whole new CT scan and a new plan was required for that patient. That's what we did for that patient in that circumstance. And otherwise, we want to look at the actions taken or plan to reduce the risk or other recommendations. And that's what you look at for what you would do in the future to prevent this from happening to any other patient. So that ends my talk today. I hope it was beneficial to you to really look through the problem types and get some familiarity with the minimum data set and the definitions. So thank you for joining me. That's it.